So that's a very special day today. Thanks a lot for being here with us. As you see, we have colleagues joining us online little by little. We're just waiting for that crowd to grow bigger, but it grows bigger by the second. So we'll be very soon joined by something like 50 colleagues who unfortunately couldn't make it. We also heard that some of our colleagues are on their way to join us here. Some of them stuck in the Brussels early-ish morning Brussels traffic jam. But welcome everyone. It's really a pleasure to have you with us. We have put together an interesting program for this morning to really have this first meeting of our rare brain disease ecosystem. You'll be watered and fed during this morning. So there will be a coffee break at 11:15. There will be a lunch break afterwards, which you are very welcome to join and attend in order to carry on the networking and the interactions. But before that, we are requesting your attention on the various topics and sessions for today. So the housekeeping elements, I'd ask you to put your phone in silent mode, but you will find the Wi-Fi code. Probably not to invite you to do emails during this morning, but rather to spread the news on social media and other networks about this event going on, but also about the messages and the key issues that we will be leveraging in our discussions. Another point of housekeeping, which is no legal requirements, emergency exits. It's probably the best way to leave this building is the way by which you came into this room, so by the main staircase, but there are also alternative signs to lead you to other directions in case an alarm is blowing out. So as I was saying, we will have our online audience joining us. The idea was to really extend the outreach from the discussions in this room today. We'll have interaction provided in the program later on as the last session. And we will really try and make sure that we can also engage with online participants. But feel free at any moment also to interact if anything is not clear or not properly understood, but elements of content or bringing the conversation forward, you will be invited to address that later in the meeting. So I'll simply start with a word of introduction on behalf of the European Brain Council to explain a little bit the background why we are organizing this event today. You've heard about this concept of the rare brain disease ecosystem for a little while now, because that's really something that we have been socializing over the last month. It really was conceived as an enabling framework to enable the discussions like the one we are planning for this morning, to brainstorm about opportunities in the rare brain disease space. The reason being that we estimate to 75% the number of rare disorders who have a neurological origin, but also we recognize that most of them, if not all of them, have very severe interactions with a mental health condition, but also have cognitive impairment as consequences, albeit that they do not have specifically a brain tropism. So we also recognize that most of the challenges are common to brain disorders, like delayed diagnostics, inequalities and difficulties in the access to care, heavy social and financial burdens, but also that we see that there is an immense potential in improving research, boosting research, but also enabling collaborations at European and international level, along the lines of what is now being done or what was generated with European reference networks, for instance. Some of the projects and activities that EBC has been engaging into in the recent past will be covered during the discussion today, but not necessarily all of them. But I really would like simply to remind what we have done in the context of the value of treatment in dystonia, ataxia, phenylketonuria, really try and address the issues in those specific diseases to really emphasize the need for seamless coordination and multidisciplinary care pathways and how these should really integrate our healthcare infrastructure. EBC is also involved in a project that is EU funded. You will find a leaflet on the table outside that is called Brain Teaser. Brain Teaser is about how to leverage AI and big data to better support people living with MS and ALS in particular, but also how to improve clinical decision making and increase coordination in that respect. Another project that you will hear about is called the value of education. So it's how to empower patients by providing information, education, and communication on how they can benefit from digitalized care pathways, which we recognize is one of the key challenges, particularly in a post-COVID era where telemedicine has really deserved like a massive boost in its implementation. And I would also invite you to check on the latest Journal of Orphan Diseases article that was authored by our experts in that vein, and it will be talked about later on. A last word also about our activities in the context of Brain Innovation Days. And the reason why I'm singling this out is that right before taking the floor, we were discussing that as to how the conversation needed to be advanced in November this year in the Brain Innovation Days 2024. But what we did in October last year was to have a session on the rare disease ecosystem and how this collaborative path could really improve the landscape, but also seek for a holistic approach and a better integration of patient needs. So I really have the feeling I've already talked too much to provide you with this introduction, but I simply would like to conclude that our aim with today's discussion, but also as of today and in the near future, is really to leverage your input in order to identify gaps, leverage opportunities, but also identify those priority areas where we could and we should build common projects. Because we recognize that as EBC, we can offer a certain number of tools, but we are certainly not the only ones. Ola, I'm looking at you because at EFNA, as a leading patient organization and patient voice, you have been doing already a couple of initiatives, and you'll be sharing that with us later on. We've been talking about like other opportunities, and I'm really pleased that Aurordis is also with us today to discuss these kind of common grounds, but also identify those areas of collaboration. So with this, I'd like now to officially kickstart and more formally kickstart these meetings and sharing with you the video message that we received by one of our patron and supporters and ambassador at the level of the European Parliament, who could not be with us today, but it is MEP Stelios Kimporopoulos. So I simply asking you for your full attention for his video message. Thank you.
Dear all, today on the Rare Disease Day 2024, we raise awareness about rare diseases. We ask for priorities in the rare brain disease research, care, and policy space. We fight together today for a better tomorrow. I would like to thank the European Brain Council for organizing this event and for allowing me to send my message. Through my personal experience, I understand how challenging it can be for a rare disease patient to get a diagnosis and access to appropriate medicines and healthcare. We have 30 million rare disease patients in Europe, and more than 6,000 rare diseases are identified. When living with a rare disease, we are faced with a unique set of challenges that often extend beyond physical health or treatment options. We are more likely to experience symptoms of mental health conditions due to isolation, stigma, and other socioeconomic factors. It is therefore extremely important that healthcare providers working with rare disease patients, society, and organizations must adopt a holistic approach by understanding both physical and emotional aspects of rare conditions. We must aim in providing comprehensive care that addresses specifically each patient's unique needs. Within the Parliament, different interest groups and coalitions are working towards addressing these specific needs and providing that support. Member States playing a key role in raising awareness at national and European level, liaising European initiatives with national decision makers, and bridging the gap with the transatlantic ongoing initiatives. 72% of rare diseases are genetic, while 75% have a neurological origin. We need to invest more in early diagnosis and further research. As a rare disease patient, an MEP, and member of a network of parliamentary advocates for rare diseases, I have committed to bring about a new EU policy framework on rare diseases and stronger EU-wide action in health policies. I'm now calling all stakeholders to move forward the conversation about a renewed EU framework for rare diseases. I now believe that with the ongoing revision of the pharmaceutical and the orphan medicinal products regulation, the time has come for the European Commission to take a step forward and demonstrate its commitment to the health and well-being of all European citizens by developing and implementing an EU strategic plan on rare diseases. This plan should encompass advancements in research and innovation, access to diagnosis and treatment, and patient and family support. Rare diseases do not only affect individuals, they impact entire families and communities. We need to establish a robust support system that includes counseling, education, financial, and psychological assistance for patients and their families. Today, we must send a powerful message of solidarity, compassion, and inclusivity. We need to address inequalities and difficulties in access to treatment and care. This day marks an opportunity to uphold our values and to foster a more compassionate and inclusive Europe.
Well, I'm sure you'll recognize, like me, in MEP Klimpopoulos, a very strong advocate. He has been working with a lot of organizations, and I simply would like to
Today, on the Rare Disease Day 2020,
echo his words. Maybe one time is enough, though. But just to say that quite a number of initiatives have emerged. One of the points of today was also to try and identify those. I simply would like to emphasize the fact that our attempt was to try and now seek synergies between those various elements of work. He's mentioning the joint action on rare disease. We obviously have the European partnership also being talked about. EBC, we are strongly involved into the development and the preparation of the Brain Health Partnership. So there is definitely a virtue to try and seek as much synergy between all those programs, but above all, avoid fragmentation and duplication. So it is in that spirit that we also invited a friend of EBC to join us today. To come and talk to us on behalf of FPA, the European Federation of Pharmaceutical Industries and Associations. Her name is Magda Chlebus. I don't think she needs a full introduction, but she was invited and gladly accepted to join us to present the Moonshot initiative that was launched by FPA as an attempt to really synergize efforts in the rare disease space. But Magda, I'd like to really leave you the floor to explain way better than what I could do what the Moonshot initiative is, and I'm glad to pass the talking baton to you for that purpose.
Oh my
Over to you.
Okay, thank you. Thank you so much. I have my telephone with me, not because I want to put any phone call out, but I hope that we would be also putting a bit of social media on this. And it's very humbling to come after a real testimony of why the ecosystem is necessary. And I think what I would like to show you today is how we can do it, what we can do, and then what is the call to action to all of us? Because I think today's Rare Disease Day, 29th of February, is just an opportunity to shed light on 6,000 individual diseases that do never have these spotlights on them. And even when we talk about Rare Diseases Days, it's 6,000 diseases. Each of them deserves the spotlights. So all of the rare diseases today should be seen. Each individual disease should be seen as well. I'm very lucky because I was drawn into the Children Tumor Foundation, and I'm part of the board as well. It is a terrible disease, neurofibromatosis. It's a disease that has many manifestations, that has many types, that can be very handicapping, that can cause pain, that can cause disfigurement, that can cause loss of limbs, that can cause a lot of very horrible things. And even though there is just one treatment on the market, it's just a treatment for one of those types of neurofibromatosis. And that means that research needs to continue and continue and continue. And the only way this research can continue and continue and continue is not by individual pockets of activity here and there, but by synergizing and by bringing everybody together. We need a community. We need a community, and that's the reason why we started to create, to defragment the field and start bringing the communities together. It doesn't mean that the European Union hasn't done anything before. There are fantastic programs, EJPRD, many of the collaborative research that is going on, but there is still today a lot of silos in this ecosystem, and what we need to do together is to work on defragmenting. And therefore, in order to give a chance to all of these 6,000 diseases where there is no treatment today, we need just to do something slightly different. So we've brought together a community of 9 organizations that represent the entire ecosystem of translational research, because we have fantastic science in Europe, but we are very slow and very bad at translating this fantastic science into products and into services for patients, into real solutions. So we brought together this community of pharmaceutical-based, research-based companies, organizations, trade associations, but also European infrastructures such as BBMRI, Elixir, etc., to EATRIS, and other organizations like Critical Path Institute, who has a very practical set of programs for rare diseases, and who create these neutral platforms on which everybody can meet, defragment knowledge, bring the knowledge together, bring the data together, and do something with that. Why did we do this? We've done this together with also Eurodis and EJPRD because it is important to break the silos. Today, as I said before, we have far too many silos. And there is also a misperception that public-private collaboration, is something suspicious, to say the least. What we would like to do is to enable these public-private collaborations, because today we need all energies, all science, all public and private knowledge and activity brought in one place. So the Rare Disease Moonshot, which is a collective of organizations from the translational research path, is actually a response to this call for paradigm change, for doing something differently, for doing that together, for forgetting our individual particular interests and seeing where we can create public-private collaborations through European calls, through European action plans at national level, and what kind of activity, practical activity, would help unlocking research in wide spot areas. The white spot areas is where there is no publication or no translational capability. I think there are spaces in the research on rare diseases where there is quite a lot going on, but there are these white spots where nothing is going on. And our goal with the moonshot was to put spotlights on these areas where there is not much going on, and to see how by putting together public-private partnerships, we can actually make a difference. So what we do in the moonshot, together with our partners, public and private, we look at the gaps. What is it that that research needs? Which of these gaps are the ones where public-private partnerships is best placed to do something? Because not every challenge can be addressed by a public-private partnership. Fundamental science will not, but translational science will. So we are looking at where we can make a real difference. Then we look at what are the public-private collaborations that exist already, because we need to leverage what has already been done. There is no point in redoing the research. And then we look at triggering new initiatives, at launching calls, whether in European programs or national programs, in order to create new public-private collaboration activities. And for that, we have identified also that there are barriers to collaborations. Not every program is well designed to facilitate public-private collaboration, sometimes because of perceived conflicts of interest, sometimes because of funding problems, sometimes because the funding mechanism is such that it is not possible to put different parties together. So that's what the moonshot is doing. We have delivered 3 sets of recommendations so far on clinical trials, on translational research, and on diagnostics. The one on translational research is coming up soon. We've almost done with that. And this is a call to action. This is a call to action to current framework programs on research and call to action to future framework programs on research. And just let me to talk about it. Here are the organizations that are part of the moonshot, and I should have clicked on that earlier. But now these are the programs that we are already leveraging today, and it's really important to take note of those because they are making a difference. They are genuinely making difference in the white spot areas, and you see those in diagnosis, those in translational research, and also those in clinical trials, because what is really important is that we start doing clinical trials differently from today. So now here under this link, you would find an article which is actually explaining what the moonshot is. So you'd find more information about it. But I would like to say a few words about defragmentation and FP10. Now, what do we need in the future? If we really want to put spotlights on each and every of those rare diseases, which do require research, especially in the very difficult field of neurology and CNS, which suffers from divestment, from particular complexity and a lack of science. We need to have a plan, a European plan. We need to have more than individual small plans. We need to aggregate and put together a massive plan, which would help defragmenting research, clustering diseases, changing research paradigms, starting to think about research in a different way. This is the call to action today, I think, to the European Union. We need that plan, we need that funding, we need that energy. The second thing is that we need to facilitate collaborations, different collaborations, public-private collaborations, private-private collaborations, public-public collaborations, all of these collaborations. We should not forget fundamental science, which Europe is doing fantastically well, but we should also support translational science, which today falls a little bit between the cracks of European funded programs. And the last point, FP10 in the future should do much bigger scale projects and programs than what it is doing today, especially in the field of rare diseases, giving a little bit to everyone or giving a little bit more to few. I know it's a trade-off to do, but in rare diseases, if we start changing the paradigm, cluster, and bring everything together, maybe a bigger fund for a little bit less, but for the translational part in particular, might really make a difference. So the moonshot would be advocating for that. We invite you to follow us, and we are not there to shine. We are there just to remind funders and the research community that we can do research differently and make a difference for rare diseases. Thank you.
Oh, that's magic. Right. Magda, just a follow-up question to that, because defragmentation and obviously recognition of the excellence in science and let's say leveraging benefits, and then that trade-off between how to then strategize what FP10 is going to be is obviously one of our key area of attention. I won't ask you what is your take between the two options that you just mentioned. I simply would like to ask you, what is the potential for spillover effect of a better strategy or a better focus like the one that you're calling for in the rare disease space? What are the spillover effects that this can generate across the board in other areas within FP10? And I should say within the entire research policy and research vision, if there is one at EU level.
I think you've said it, Fred. It's there would be a spillover effect. I mean, let me maybe take a step back on FP10. I think first of all, it's not too late on the Horizon Europe. And we should be very clear on that, that it's not too late. There are still calls that are coming up, and there are still instruments beyond FP10. There is EU for Health. There are many programs in the European Union that already today, if we had a mission-like goal, an objective, I think a lot of things could be done slightly differently. So I would say that today we have that opportunity. For FP10, I think we should take example, and I'm not calling for a rare disease mission. Let's be clear. Missions are very complicated to put in place, and missions are very bureaucratic, to say the least, at least the way they are materializing, not when they are implemented, but the time it takes to materialize a mission it's quite a heavy process. But if we have that one big goal, and if all programs are encouraged to contribute to that one big goal, and if the funding is also organized so that the scale can be created, and if we also put that attention on the white spots, because I think that's what today it's a little bit missing. There are many diseases where there is between 0 and 5 publications only. You cannot have a research program just based on 0 to 1 or 5 publications, right? So if we can do that, then there would be a massive spillover effect across all programs, and that would create attraction. It would create, I think more energy in this space.
And just on that, on the issue of the white spots, because I recognize one of the challenges that we faced when we did the European Brain Research Area project, where we are trying to identify the clusters, or let's say the networks of researchers, multidisciplinary, of course, but in certain areas. Do you recognize there a challenge to try and identify networks of researchers in those white spots? Because you say if there are less than 5 publications in certain niche areas, is that because we have an issue with the let's say capacity or manpower there, or the scientific interest, or maybe then the network of colleagues working on a similar topics? Is that something that you have seen already, or?
I should defer that question to the scientists who every day try to find their network funding, etc. I think there are tight-knit communities that know each other, and today there is much more and faster communication between physicians, between clinicians, between fundamental researchers. But yeah, probably because rare diseases are many of them are so rare, and with so many manifestations, that creates a real complexity that could be optimized. Whether there is a problem with finding peers to work together, I don't know. I just know that from the industry point of view, it's very difficult when you either don't have anything to translate, or where what you have to translate is not of the quality grade that it's required, of the regulatory grade, of what regulators need in order to bring research to the next step of research development and then submission for a marketing authorization, for example. So I think white spots are due to either lack of science or due to lack of translational capability. And if Europe could really put more focus and emphasis on this translational capability and facilitating collaborations and putting together knowledge, resources, manpower, the innovation capability from small, medium, big companies and the academic community, I think that would make a very big difference in Europe.
Thank you. Thank you very much, Magda. And it resonates very strongly with quite a few of activities, as I said, and you can really count on us to try and contribute the best we can, but also with the tools and the past experience that we've developed. Thanks a lot.
Thank you.
And thanks for making the time to be with us today. We are now opening session 2 to give really the voice to patients and caregivers, advocates, and also patients and caregivers by experience. And I'm pleased really to welcome another friend of EBC, Mr. Tim Bookings. So we've really met Tim in a context where he was sharing with us his experience as the father of a kid with epilepsy, and that led him to become the CEO of Epi Hunter, that he came and present on multiple opportunities. But Tim, I know you're coming today with another personal message, which I would like to invite you to convey to us, and really much appreciated that you're also taking the time to come today. The floor is yours.
Happy to do so. Thank you. So indeed, my name is Tim Bookings. I'm a parent of a boy with refractory epilepsy, and there you go. So actually, we're very lucky. My wife always tells me that we should buy more lottery tickets because I have a rare disease called Evans syndrome. I kill my own blood platelets, white blood cells, red blood cells. It's not that good. But I'm still alive. Thanks. I live on steroids. And secondly, my son has ring chromosome 20, which is an ultra rare epilepsy. 20th chromosome goes into a ring shape and causes refractory epilepsy, meaning many different drug cocktails. Still daily seizures. Whenever he doesn't take his medication, he's a 19-year-old pain in the butt. Or when he spends all night looking at YouTube, then the tonic-clonic seizures kick in very frequently every half hour. But on a normal day, he only has absence seizures and he has an absence status epilepticus of approximately 30 minutes. It looks like daydreaming. So we're very lucky, are we? So when I am asked about the impact of a rare brain disease to the family, I always see three main components. One is the emotional one. Obviously, during the diagnosis phase, it's the whole dreams of the child, but also the parents that's scattered, destroyed. You don't know what will happen in the future. You don't know what to hope for anymore. But when that condition becomes refractory, that doesn't go away. It still remains a mourning every day again. And to be honest, every day I'm very happy and relieved when my 19-year-old pain in the butt rolls when I wake him up in the morning, because it means that he's still alive. And that's the burden we carry every day. Secondly, what also happens is the social isolation of the family. Imagine normal family, they plan trips with another normal family to go to an amusement park, but our child had a bad night and we can't go to the amusement park. And that literally means that that family will never make an appointment with you anymore to go to trips. And that way, step by step, as a family, you get in isolation. And especially with seizures that are very difficult to notice, because everybody will say, hey, he's very silent. So aren't you overreacting? Why can't he go with his bike on the street? Yeah, but it's dangerous. But people don't see it. Whenever you have a tonic-clonic seizure, everybody's scared and it's so bad. But having these kind of seizures every day again, multiple times a day, there's a lot of misunderstanding. Misunderstanding in a social context, but also in a context at school where teachers don't notice the seizures, for instance. And then the third impact is financially. very highly underestimated. Having seizures means that you have bad nights, that the child can't go to school. It means that you need to pick up your child from school at certain moments. It's the unpredictability, total unpredictability. It means hospital visits. It means hospitalizations for multiple days. And that means in most times, and I'm very sorry for this, but the mother stops working. And you still need your second car. You need to overcompensate sometimes on social events. So you really get into financial issues. And in many cases, the father just struggles to keep working. So perhaps let's dive in a bit on the absence seizures and absence status epilepticus, very much looking alike. So if you look at absence seizures, it's the most common pediatric epilepsy syndrome. And it's called childhood absence epilepsy. But on the other hand, if we don't look at epilepsy, but we look at the seizures, then it's also very common in many, many different rare epilepsies, in all kinds of shapes and different labels and names. And to be honest, labeling seizures is crazy. But anyway, because there's a lot of new names popping up, etc. And there are some current gaps in that are with an awareness, and I can't read them myself anymore. The unawareness, and also an in-hospital evaluation with EEG is just a spot check. There's a lot of questions. Hey, is this happening now in the evenings as well, etc. And then what does it mean for the child themselves? And that's where on March 15, 2015, one of those father-son conversations with my son, at that moment he was 10 years old, and we would obviously speak a lot about the impact of his epilepsy on his life, where he said, Papa, you work in digital. Can't you create a light that turns on when my brain switches off? Because then my teacher isn't angry at me anymore, because she can see my seizures. And that having a professional history in digital technologies, I said, yeah, damn, this should be feasible. And I thought, let's quickly do that. But in the end, we succeeded in this. This is how our current solution looks like. We use wearable EEG, very thin headband. It sends raw EEG data to a smartphone. And whenever such seizures pop up, we turn on smartphone light. And because the teacher sees it from a corner of an eye, they can intervene, they can give more time for a test, etc. But what it also does, and by doing that, we take away the impact of those seizures from the classroom. But it also does is it alleviates reporting pressure for parents, because your neurologist will ask you, so how is it going the last 3 months? And we have to guess a bit. And we asked the teacher and they had to guess a bit. But now we can bring objective data to the table. And that makes that conversation so much more valuable. And then thirdly, of course, the information for the physicians. So this became a product. It is the #1 worldwide first wearable solution for real-time absence seizure detection and signaling. It's clinically validated. It's on the market in Europe, Australia, and New Zealand, and it has been medically certified as well. And it's supported by 9 publications. But what's then the relevancy for many other rare epilepsies is the aspect of looking at seizures at the level of seizures and not looking at Dravet, or we are looking at LGS, or we're looking at ring 20. No, it's looking at those seizures that are very much and are a commonality between these different rare epilepsies. And then something happens. And it was something that was in the back of my mind from the first time at a hackathon at UCB, my conversation with a neurologist expert there. And during our clinical validation study, something came up. What about the potential auditory neuromodulation potential as a digital therapy for absence seizure? And I've put there on the bottom right, we're not speaking about neurobehavioral. If we look at digital therapeutics in brain and mental health, it's a lot about neurobehavioral. We are talking about neuromodulation of changing brain state by auditory stimuli. And to us, yeah, I'm not going into it because otherwise it will take too long. But that is what our next goal is, create and deliver worldwide first evidence-based and cost-effective digital therapeutics for people with a brain disorder. And we started with absence seizures to reduce the seizures, but we also moved already into Parkinson's, where we're looking at freezing of gait. We're doing a proof of concept with Gay Leuven there to use auditory stimuli again. EEG, wearable EEG, capturing and detection of the freeze in the brain, and then doing auditory stimuli to inhibit the freeze of happening. And it's really exciting how this idea scaled that much. And then you have the triple aim of digital for healthcare. You have the quadruple aim. Yeah, I like this sextuple aim because of the top right one. Caregiver. Do not forget the big impact of the families on rare brain disorders. And I think we should have more attention for those because they keep the person with the condition, in many cases, alive, but also too alive. And we should care for their life as well. And to be honest, in healthcare reimbursement, there's very little attention for that aspect. And one of the bigger outcomes of our product to date has been that mothers are able to go back to work, but there's no reimbursement code for that. And that makes our lives as a company startup sometimes difficult as well. And then I regularly compare it to the glasses that we are wearing. They never cured anyone's eyes. We're using them since 1290, where they were invented in Pisa. But what they do very well is take away the impact of our bad eyesight in daily life. Thanks to these glasses, we can drive a car, we can do our jobs, we can look into each other's eyes. Without these glasses, I would live on the edge of society. So perhaps we can create digital products that do the same impact. Thank you.
Once again, it was very telling, and thank you for sharing that with us. I very much like your sextuple aim, but would you really say that your caregiver experience, and I would say even personally and external experience, is that your competitive advantage in your critical success factor?
I think I'm very lucky. I think the power of healthcare, how should I phrase this? I think there's something powerful of digital innovation in healthcare. There are many fathers and mothers like me who get stuck in a personal story, and they dedicate the profession, they switch their professional life to doing this. And I compare it as well to the best and most beautiful music is not created by artists that are living a luxury life. It's created by artists from the personal pain. And I think that that can be a very strong motivator for digital innovation as well.
So a living story of turning a challenge into an opportunity.
Yes.
And how being the father of a son with epilepsy, how to become an entrepreneur. So congratulations again, and we look forward also to the successful development of your Parkinson's application. I think this is definitely something we'd like to know. But thanks for being with us later today. And obviously, I would invite anyone to interact with him during coffee breaks, but also during the conversations later on. And thanks a lot.
Thank you.
At the stage, Michael Johnson from Eurosis, Red Zero. So Matt, we invite you and thank you also for accepting this invitation on the basis of extremely for the people. But Matt kindly accepted to come and talk to us about the initiative led by your office on mental health and well-being for people with a rare condition. So, Max, over to you.
Thank you. Thank you for inviting me. And to be honest, coming here on Rare Disease Day and talking about mental health, for me, is the best way to celebrate rare diseases, because it's putting a spotlight on mental health in the rare disease community. We need to increase the visibility of the impact of rare conditions on the 300 million people globally, on how what we've heard from Tim is not alone. Tim's story is, I've heard time and time again, whether I engage with patient representatives from children with birth malformations or from rare and complex epilepsies. Across the board, I hear the stories which Tim has so eloquently explained, repeated. So for Rare to be here today and actually shed a light on mental health today is really important. As a community, rare diseases, we are constantly in one or two states. We're crisis managing, we're hunting for a diagnosis, finding the expert who knows, pushing research for a cure, or we're alone. And it's when we're alone that the emotional impact of living with a rare disease impacts us. And it's when we're alone that actually the isolation builds up, and we need to be connected, and we need to address those things. For too long, our advocacy has been focused on diagnosis and research, etc. But our community is now mature enough to give space to addressing the mental health needs of our community. It's important to say today that all people living with rare disease, your mental health matters, and it's now time to take action. The European Commission is doing a brilliant job with the new comprehensive approach, but we need to make sure that rare diseases don't fall between the cracks. That I think the enemies of rare diseases are that we're either isolated or that we have siloed thinking and siloed policies. People with rare disease don't just live with one thing. They live a very complex set of needs. They live at the intersection of multiple communities, whether it's living with a visible, invisible disability, being a child in today's society, or living with comorbidities, multiple comorbidities. All those build up and accumulate. And in a way, mental health and rare diseases, we need to make sure that in research, we bring those two things together. So research is focused. The new European Parliament did a publication on their own initiative report highlighting that mental health research is needed. So we need to make sure that rare diseases and mental health are addressed in that. And also mental health was raised as a high burden, under-researched area by the expert group at the Commission. So we need to centre rare disease. We need to centre these vulnerable people in vulnerable communities or situations at the heart of policy to address their needs. So for too long, mental health has been unseen and neglected by being overshadowed by addressing the other medical complexities. And conceptually, we think about the impacts of mental health on rare diseases, or the other way around, sorry, is on an individual level. Someone can have a rare condition where mental health is a primary characteristic or a comorbidity. At a population level, everyone who goes through the rare disease journey goes through the diagnostic odyssey, getting a diagnosis and giving a diagnosis with a poor prognosis. That brings a lot of stresses and strains where we all are affected, not just the individual, but the whole family. We have statistics at Eurodis where we pulled together, we've done some research. 90% of people with a rare condition feel depressed or anxious. Nearly 20% feel suicidal. That is a really high number, and we should not look away from that number, because they're the people who are most in need. They're the ones who are most isolated at this point in time. We need to reach out and connect to them. A third of patients, of parents of children on the undiagnosed pathway can be classified, meet the criteria for mild or moderate depression or anxiety. And we heard earlier about the impact on people's finances and being able to work. I think nearly 80% of people living with a rare disease have to change their career aspirations, have to change, like Tim's wife, or, you know, you have to change the environments because you have to deal with all those tests and going to hospitals several times and managing the day-to-day care. So we've got a proven evidence base around the impact that rare conditions have on mental health. One of the key stages of the rare disease pathway is diagnosis. Having a diagnosis is life-changing. If it doesn't make you feel stressed or put you under immense pressure, I think that would be not right. It's a life-changing bit of information which changes your whole view of life, your aspirations and everything. So we shouldn't medicalize that. But how diagnosis is given, we've got some clinicians in the room. If it's done in a way which is empathic, where we give proper time to this, it can empower someone, a family, to step forward and take on the challenge which is being given to them and live a life and optimize their life going forward. If it's done badly, it destroys lives, it destroys relationships, and it casts a long shadow over the whole of the rest of the pathway. Trust in medical clinicians goes. Any form of interaction thereafter is viewed through this lens and experience, which is really traumatic. The uncertainties which people live with a rare condition, the stresses and strains, these are chronic. They're lifelong. Some people never get a diagnosis, so they're constantly in that place of what's going on. They get told that it's all in your head, we can't find what's wrong with you. Sometimes families are questioned, mothers in particular question, social services come around going, what are you doing? You know, and some children are taken off their parents because of being stuck in that undiagnosed pathway, not because of their care, but because of the lack of knowledge and understanding around what's going on with that child. And this sense of isolation, when you get a diagnosis for in 20, you go to see any form of healthcare professional in primary care, in emergency services, whatever, and they don't know, ring 20, what's that? I understand cancer, but rare conditions. That makes people feel isolated and frustrated even more. The interplay between the physical and emotional and mental health side of rare conditions is clear. And all this places stresses and strains on the family. We're starting to see action taking place. Our beloved UN resolution actually has a line in there, a recommendation, which I love. And it calls on member states, the European Union calls on member states, all of the ones in the EU and beyond, to take action to develop psychosocial programs for people with a rare condition. The WHO, through the pandemic, highlighted people with an existing health condition, which can be chronic or rare, as a community in an increased vulnerable situation, which was disproportionately affected by the COVID measures. And in the European Union, what we're seeing, the definition in the new comprehensive approach, it lists a lot of communities in vulnerable situations, but it's not comprehensive. Does it mention rare diseases? No. We advocated hard on that. But, you know, with an outgoing commission, it's hard to do new priorities and commitments for the incoming ones. But what I can say is the definition in the implementation of the communication has started to shift. When the commission did a call for best and promising practices, we saw that they were being more inclusive. They included in there now in the definition for people in vulnerable situations, people with chronic conditions and multiple comorbidities. And a lot of people living with a rare brain condition fit into that category. But more needs to be done. What we also heard from our community is we feel really pleased. We go to Antwerp and to the University Hospital there, or we go to the Necker in Paris. We're really pleased actually about the quality of our medical care, which we get in these expert centres. However, our physical care needs are met, but our psychological and emotional needs aren't met. And so actually we need to not think about solely about the biomedical aspects around this, but the psychosocial. We need to, this call for the UN resolution to develop psychosocial programs. What does that look like? I'm a native speaker Brit in Europe. Well, I'm actually German now, and I struggle with psychosocial. I don't understand what that means. For me, what it means is it's not more mental health services. It's more about the medical care which is being given in our hospitals is enhanced to being more psychologically informed. So we're pushing at the moment a position paper which takes that UN resolution to the member states and try to explain to member states what that actually looks like. On a European level, we want to make visible rare disease in the mental health space. At a national level, we want to make visible mental health in the rare disease and national plans, because that's been missing. What we've been doing in Eurodis is, for the first time, we've created a network, a partnership network of patients, clinicians, researchers, which gives space to people living with a rare condition to say that your mental health matters, to come together, to share, to support each other and find solutions. This is an open network for anyone to get involved. More information is on the website about the activities we're doing. We're connecting with mental health researchers from the recent cost actions which have been finished on mental health. And I think they'll be good to connect with European Brain Council. They're looking to push research in mental health as well. We did a European Parliament event last November where the Telemeds and Sarah Sardis came and championed people in vulnerable situations. So this was, if you talk about rare diseases in isolation in mental health, we won't get anywhere. It's only by standing in solidarity with other people in vulnerable situations, women, migrant women, HIV, disability community, that when we stand together, actually our voices are the same, that has a bigger impact. So we've been making some progress, which I won't go into. I've covered it, I think, already, but thank you very much.
Thanks a lot, Matt. Actually, you anticipated the question I had for you, which was the potential for collaboration and learning from other organizations' experiences and leveraging this type of learnings, because you mentioned your links to the cost program. That's obviously an initiative that we have also supported, but there is certainly the potential to go further. We haven't gone through your stepwise program. Is that part of it? And is there a potential for EBC and EBC member societies to also be part of that?
The advocacy which we're doing in terms of describing what psychosocial care looks like for our community, we want to do it as a bottom-up approach. There's a very good German/Austrian paper on it in pediatric oncology, but what does that look like in rare diseases? What does psychosocial care look like from the patient community perspective? We can co-create and work on that together. I think my message today really is around, we look a lot at the biomedical and we think of it from that perspective. If we only focus on that, we will fall short of meeting the needs of our community. There's a wider set of issues around psychosocial interventions, policy actions to address stigma, address isolation, which we need to be pushing as well. We need research in both. We can't just look at one area. We have to take action on both.
No, absolutely right. And it resonates strongly with many of the brain disorders that we are looking after, rare and not rare. So thanks a lot for making that point. And obviously, same thing, would like to invite you to take any comments or reflect on Matt's contribution during the interactive session. And I'd like to move on, sorry, Matt, but we are a little bit under time pressure. And I'd would like to invite our board member and executive director of EFNA, the European Federation of Neurological Associations, to present to us the charter on rare neurology that you contributed to and spearheaded. So Ola, the floor is yours.
Thank you so much. For those of you who don't know who EFNA are, and for those of you who think we focus on neurology, we do. But the reason we focus on rare neurology is that, in fact, so a quarter of our member organizations, which are pan-European, are dedicated to specific rare neurological conditions. But more than that, we have other member organizations that focus, for example, on epilepsy, who, as we've heard earlier, have a huge cohort, have rare epilepsy conditions. Again, with MS, we have a huge cohort of NMOSD patients due to misdiagnosis. So even though we have groups that are not rare neurology specific, they have rare neurology embedded within their communities. So today I am going to talk you through some of the community perspectives that led to the establishment of a rare neurology charter. And next week, there will be more detail on the call to action as our president shares that with the EBC event in Parliament. So some of the topics around the challenges have been spoken through today. Rare neurological conditions are a hugely underfunded research area and are often neglected. There are delays and absences of diagnostics, and a delay or an absence of a diagnosis not only leads to a delay in treatment, because we know for many conditions there are no treatment options available, but also access to care, access to services and supports that are crucial to the family environment. And we heard about that earlier today. There's also that negative impact on social life, not only of the individual, but also the parents, and the siblings of children often are neglected in this conversation in terms of education and employment opportunities. What is available is often inaccessible and very expensive. Sometimes that is treatment options, but again, sometimes this is simply access to services and supports. We know that Europe isn't a united health union in the delivery of its care, but beyond that, at national level, we have huge discrepancies between people with their urban and rural divide. So it is, if I can say this, much easier to be someone with a rare neurological condition in a city where there is really good transport system, where you have those high-end medical centers, versus someone who lives in the countryside who has to rely on a taxi service, a neighbor or a friend to maybe bring them into a town to get a train to get to a city. This all leads to the massive negative socioeconomic impacts on the individual level, the family level, but also on the national level. So throughout the establishment of the Rare Neurology Charter, we decided to take a look then at some of the opportunities for learning and for leveraging. What we don't want to do is to create something new. What we want to do is leverage what is already there. There is power and strength in numbers. We do have a number of policy levers. There is a momentum behind the rare neurology community, and we have a timely opportunity ahead of the EU elections. So some of the examples and case studies that were presented in the Rare Neurology Charter centered around the revision of the Orphan Medicinal Product Regulation, and that has huge links to the revisions in the HTA regulation and in the revisions of the pharmaceutical legislation. We heard a little earlier about the European Partnership on Rare Diseases, which is ongoing, the EU for Health Programme and Non-Communicable Diseases Initiative, Healthier Together. So again, this is of particular interest because it links both neurology and mental health together. And again, we've heard from Matthew about the importance of mental health and where there are these huge ties. Another major opportunity is the establishment, development and progression and the inclusion of patient organisations in accessing the European health data space. And this is something that research institutions, patient organisations, health system executives at national level should really be taking the time to invest in. We did touch a little bit on numbers today, and numbers are a huge challenge to the rare disease community, but also to the rare neurological community. So if we take an example taken from the website of ERN-RND, they state that more than 500,000 people are living with rare neurological disorders in Europe. But what we know is that actually Many rare neurological conditions fall under many of the ERNs. So that number is actually tiny. And if I give an example of a condition that you probably won't even think of, because the WHO has said that polio is dead in Europe, and it is, but we have 600,000 post-polio syndrome survivors in Europe. And that's one condition. So the number on your screen is actually quite small. Two of the learning and leveraging opportunities that I want to draw your attention to come from one, the neurology community, and the other, the rare disease community. And they are the WHO's 10-year intersectoral global action plan on epilepsy and other neurological disorders. And the second is the Rare 2030 recommendations. These policy hooks are actually more similar than you might think. So what we are aiming to do is to combine the best of both of these case studies, these policy hooks, these opportunities to learn and leverage, to address barriers and challenges, to create optimal living for those impacted by rare neurological conditions, and to provide sustainable solutions to improve the quality of life for those impacted by rare neurological conditions. And actually, we are at a 5-star moment where we have the policy levers and we have the political triggers. So if we take a quick look at the guiding principles of the WHO's IGAP, first and foremost is highlighted on your screen that it is people-centered. So this is relating to the people who are affected, the individuals themselves and their families. That solutions are sustainable, that they're integrated also across the lifespan, that they're evidence-informed. So again, we have that numbers issue. Evidence-informed policy and practice, that there's intersectoral action. So again, we heard this, we can't act in silos, we have to act in solidarity. That there's empowerment and involvement of patients and families, and that the basic human rights, gender equity and human rights are included in all of the decision-making processes. If we look at, if you even take just the first panel, if we look at the strategic objectives of the WHO's IGAP, it's to raise policy and prioritization and strengthen the governance around neurological conditions. There's nothing to say that this cannot be a rare neurological condition or rare neurological conditions as a whole. And what we're talking about is creating awareness plans and strategies and advocacy programs at national level. The second is to provide effective, timely, and responsive treatment and care. This can't happen without a diagnosis. The third is to implement strategies for promotion and prevention. So this is what you can do at an individual, family, and national level to promote optimal brain health. Number 4, many of you here are already involved in this, in fostering research, innovation, and strengthening information systems. And number 5 is specific to epilepsy, to strengthen the public health approach to epilepsy and using epilepsy as an entry model to the IGAP. Let's look at the Rare 2030 recommendations. Number 1, long-term integrated European and national plans and strategies. Does it sound familiar? Earlier, faster, and more accurate diagnosis. Number 3, access to high-quality healthcare. Number 4, integrated and person-centered care. Number 5, partnerships with patients. Number 6, innovative and needs-led research and development. Number 7, optimizing data for patient and societal benefit. And number 8, available, accessible, and affordable treatments. There is huge overlap if it's not already obvious to you. So what we did was build on this, and in consultation with our membership, with other stakeholders, put together recommendations within the Rare Neurology Charter. So I have 2 slides on this. The first is more funding to support the rare neurology research community. The second, often forgotten, is to promote natural history studies, because again, we have that data, we have that numbers issue. 3, multidisciplinary approach to rare neurological conditions. Again, mental health is hugely important here. Number 4, a holistic appreciation of the impact. And again, thank you, Tim, for really outlining that beautifully earlier. Number 5, patient and public involvement in decision-making and in the design of treatment and care processes. Number 6, to take action with a united and empowered voice. Number 7, to increase public awareness. This is so important. And again, Tim, that example of the invisible issues of neurology was very, very well highlighted. Number 8, health systems and HCPs really do require increased education in rare neurological conditions. It is so difficult for people to, in many cases, access a clinician and then a neurologist who sort of understands what they might be going through and the condition that they might have. They visit multiple clinical sites, they take many years. Some people are just told to go home. So we really do need a greater education in the rare neurology healthcare practitioner space. We also recognize the value of precision medicine and care. And again, some of the major advances are made in the rare disease space, and this is fantastic and should be celebrated. Number 10, the orphan drug legislation needs to be optimized for rare neurology. Number 11, we really need to improve disability assessments. And again, I draw your attention to the invisible issues with rare neurology. Number 12 is to leverage the EU health data space. And number 13 is to realize the potential of the revision of the EU pharmaceutical strategy. So I also, very last minute, and thank you to Dien, who added this last little link to an article that was published on the 27th. I do hope that you take the chance to read that if you can. I also want to make you aware of activity that EFNA is doing in relation to the EU elections. So with our membership, we have designed some political campaign assets that can be used to leverage the MEPs at national level. I'm looking at Eva, who did the translation, so they're available in 8 or 9 different languages. Addressing MEPs, we have a list of the MEPs who are running by country, and we encourage everyone, particularly patients and families who can often feel disempowered, that actually you have the power to vote. You have the right to vote, you should vote, and I hope that you all encourage everyone you know to vote, and know who the people you are voting for, what they stand for, and ask them to stand for neurology and rare neurology. I would also like to thank, especially, I saw you, Matthias, and I meant to say this, the initiative of the development of the Rare Neurology Charter was established by Alexion AstraZeneca now, and we thank you so much for letting us run with this and take this forward. Thanks.
Thanks a lot, Orla. Obviously, I mean, today could certainly meet a few of the elements or the priorities that are being called for in the charter. If you would have one wish in terms of what we achieved today, what would it be? I know it's a tricky question. $1 million. So
I want, go big or go home. I want it all,
Okay, super. Okay, no less than that. Thank you. And I now need to provide a word of apology for having done a terrible job in terms of timekeeping, because I realized that now should be our coffee break, but we still have 2 contributions to receive. So if you allow, we would slightly move our coffee break for enabling us to listen to our colleagues coming next. And I would like to invite Matthias Heck from Alexion to come to the floor to talk to us about the initiatives in the space of NMOSD and myasthenia gravis, and to provide the perspective from the industry as we enter the session 3 on industry innovation trends. So Matthias, over to you, and no pressure whatsoever in keeping these people away from their coffees. So please take the time to lead us through that.
The best spot. So I'll be brief, but not without starting this presentation of saying thank you myself. Ola, thank you. None of what is going on there, this impressive work would be going on EBC for bringing the community together today. If there's one bottom line, nothing can be achieved in isolation. That's for sure. It needs everyone to come together, and events like this, I mean, obviously, Eurodis, Magda, the work you've mentioned that is going on, NF1, 2, and all of the other manifestations. It's so important that everyone kind of puts their weight behind it, and a day like this is where we can make some of the things happen. I have the opportunity, even though we have that wealth of the rare conditions, to speak on two of them. And what I'll try and do, rather than go into very big detail on all of them, is to pull out some of the factors that I think cut across the board of rare brain disorders, and highlight where the specificities of these disease areas can serve for us to move forward and advocate for those solutions that we need. The first one is NMOSD, and you see a couple of symptoms here. So it's important to see that. I don't personally like slides like this in the sense of it shows what's going on, but it doesn't really show the experience of somebody who lives with such a condition. It's a rare disease. The estimates range from 0.5 to 4.4 diagnosed prevalent patients per 100,000. But what is important, what I would like to call out, is that it is characterized by relapses. And Tim mentioned this earlier, this impact of unpredictability. And that is something that people living with such a condition experience every day. And it's really a characteristic of that condition. 85 to 95% of NMOSD patients have a recurrent disease. 25% have a relapse in any given year. So you will imagine what that means if you have that, right? So and it comes without warning signs. You live your life, and then at any moment you can have those effects that you see here, which I won't go into too much detail there. We've heard about the impact on a societal basis, and Tim mentioned that impact on mothers predominantly. And what's bad about this disease, NMOSD, as well, is that it affects the female population a lot more, disproportionately more. 80 to 90% of the patients are females. We can and have an obligation to do something here in the EU, as we're here in Brussels today. 37% of the patient population is in the EU, US 40%. And we also see, as we've heard earlier today, about there are different variants of the attacks that can happen. There are some which occur more often, less severe, and then there are the ones that are more severe. And that is also a characteristic that you can't really know what is going on. You have a variable speed of onset. You have a variable severity of the effects. And what is also highly important there is to detect and stop the disease, is because if you have a recurrent event, the majority of patients would experience an irreversible damage. So you see the importance of stopping when it can be done. At the very beginning, MEP Kimperopoulos mentioned the importance of diagnosis, and this condition, NMOSD, is characterized by a high degree of misdiagnosis. It's, again, cuts across the board for rare diseases, and here it is. 65% of patients are initially misdiagnosed with MS. And that is another point that we experience in the space of rare diseases, that physicians are aware of some disease areas more than of others, right? And it's important that action takes place in the space of disease. Fred, you mentioned this in the beginning of the meeting, right? There are important materials out there. But it is, of course, a challenge when due to a lack of awareness, such a high amount of people living with the condition are misdiagnosed. I'll move on to the next disease, myasthenia gravis. It has some similarities and also some differences, which I can call out and would like to call out because they relate to the slide that we did see before in Matt's presentation around the stresses of living with the condition. And probably when I look at this disease, you can see it affects, again, quite a variety and number of areas of the body itself, but then also it is a fluctuating disease. And what that means is it does not manifest all the time in the same way, in the same severity. That has a huge impact on the treatment. Why? Because depending on what time of the day you would go and see the physician, the perception of the physician will be very different. In the morning, what the disease does when you wake up with that condition, it's definitely a lot more, you have a lot more energy than throughout the further course of the day. And it's very hard to imagine that when you don't live with such a condition. It's very hard. We try, and so I can make some advertising for you for the Brain Innovation Days, where there will be an opportunity to, in a virtual reality experience, to see some of that. It's immensely impressive. It is something that for somebody who does not live with a condition like this is hard to imagine, and the same holds true. And I do not wish to be misunderstood here to saying, oh, physicians should know better. It is difficult. It is difficult for everyone. That's why the points that were made numerous times, and I think in every presentation that has been given, and probably all of those that will come after mine, the awareness is key. The awareness is key, but then also the ability of patients to make their concerns heard, people who live with these conditions. Also here, the majority of the people that are affected are females. It's less strong than in NMOSD, but still more than 50%. And we also have the issue of the misdiagnosis here in this space, which is unfortunate. Time to diagnosis varies also, as we were talking about, the need for good data, the times for diagnosis. You have very different numbers when it comes to the experience. It goes from 12 months to about 5 years. Again, probably related to what we heard about today. Ola, you said it. There is not one health system that patients do have access to, but it's a very kind of individual case of where you can be treated, what is at your disposal, and maybe also who you encounter with, what kind of support level you have from the patient groups and so forth. So I think, what is it that we can do also standing in Brussels here today? Something like this, to have the combined wisdom, as it were, of the community to push for some solutions, some changes. Those are the opportunities I think that we have. Needless to say, for everyone here in this room, new commission, new parliament, new opportunities, as it were, but also ongoing. If we think about something that's also mentioned in the charter, the legislative framework, there are big or huge opportunities, once in a lifetime, once in a generation, I should say. But I think some of the points I'd quickly like to call out to finish is really on the laudable efforts that the European Commission are doing to advance all of those objectives that they've listed out, and that everyone here and online can subscribe to, I'm sure. The Parliament has an opportunity to amend those in a way that they are even more impactful than suggested. Today, of course, Rare Disease Day, Jan Le Cam of Eurodis speaking, having a dedicated session in the subcommittee on public health, which I think shows the relevance and the success of the work. It's worthwhile to engage, to have that. That is quite amazing. I think some of the points that the Commission have put forward, can be improved, as we've heard, or shall we say, aligned with some of the realities to create a concept of a high unmet medical need. Yes, there is work ongoing, but then why would you write a proposal where the people who will be consulted by the European Medicines Agency would be HTA authorities, payers, but not the patients, not the physicians? That will be changed, I'm very sure. Also, the question around high unmet medical need, is that only because we write it on paper that this should be looked at, that it happens? No, it relates to the realities of research. We've heard that from Magda, in so many conditions. The amount of knowledge is low, 0 to 5 publications. You said it. So what are the realities? I think the European Parliament really has a huge opportunity here. And of course, legislation is one thing, a tiny element. It's an important framework, but more than that, I think with the initiatives that Eurodis have started there around an EU action plan. So to really take a holistic view on what's needed, and not only in Brussels. EU legislation or EU initiatives can do great things. We've talked about the ERNs, but integral work has to take place, member state level, across so many boards. So I think we really do have a great opportunity. So I think in summary, I think that what's really important, it's for those two diseases that I quickly touched upon, but across the board, it's to recognize that the perception and the experience are two different things and should be better aligned. It's also that the recognition of the burden, as we've heard, and that we all need to work together, and it cannot be one shot. It not be one single piece of legislation. Can be this one event today. So great job to keep the momentum with the European Brain Council. Thank you very much again also for the Brain Innovation Days later in the year. There's so many things that are ongoing, but it takes each and every one of us, and super happy to be with you today. Thanks so much for this opportunity.
Thanks a lot, Matthias. And actually, it's music to our ears, as you rightly said. So very glad to have your contribution and support, and very much looking forward to the next steps in the year. Thanks a lot.
Thank you.
I'd like to invite maybe Juan already to come to the floor on behalf of Amelix, another partner to EBC in our journey. Amelix, with whom we have worked equally together in the past and look forward in the future. But Juan, you're coming. Sorry, I'll probably say your full name, Juan Jose Fernandez Romero. You should sit on or stand on an equal foot with your other colleague speakers. So you're going to talk to us about the trends in ALS. So over to you.
That is correct. Well, thank you very much for the introduction. Hello, colleagues here present in the room today, and also those following online. My name is indeed Juan Jose Fernandez Romero, and I'm the lead in government affairs for Amelix Pharmaceuticals. I understand that we are a company you've probably not heard about yet. So in the presentation today, I will introduce you briefly what we do, who we are, and the ALS field, which is our main focus at the moment. Now, what is our mission? So in Amelix, our mission is to one day end the suffering caused by neurodegenerative diseases because of the impact that these have in the community. And more concretely, our focus at the moment, or the thick of our focus at the moment, is on ALS. And I will briefly explain why. Before I get there, by the way, I should have mentioned today it is Rare Disease Days. Of course, in Amelix and here in the room, our minds, our thoughts are with those living with rare diseases, particularly neurodegenerative diseases. And I also wanted to thank the European Brain Council for the invitations to speak here and congratulate the speakers that took the microphone before me for the excellent job that you all did. Now, moving forward in the presentation, what is our global commitment? Well, we are a young company. We were founded not barely a decade ago in the United States, in Boston, where our headquarters are. Although we also have operations, as you can see, in Japan, Canada, many European countries, and we're expanding activities across the Middle East, Asia, and America. Our European headquarters are in the Netherlands, not too far in Amsterdam, and we are expanding operations in Europe. Now, this is said, all that said, what is innovation for us? Well, for us, innovation in health implies two things. First one being advancements in research for therapies, and secondly, and most importantly, particularly today, to have an interdisciplinary understanding of care with a person-centered approach. We consider, and I'm pretty sure that you all will agree with me, that there is an urgency to address the neurodegenerative diseases at all levels. And this is something that we all need to work together on because we can make a difference. So what you see on the screen now are the key facts. Broadly speaking, there is roughly 1 billion people in the world that are directly impacted by neurodegenerative diseases. There is also a worldwide demographic transition that has led to an increasing number of older adults with chronic neurological conditions. And as you know, the population of the European Union is rapidly aging, and in parallel, that is the number of people living with neurodegenerative diseases. And roughly 6.8 million people die every year as a result of one of those disorders. This means, and I'm pretty sure that we all here in the room, we all know someone who is impacted by a neurodegenerative disease. This reminds us not only the urgency to act, but also the fact that we can do something about it. In Amylyx, our work is, of course, we cover several neurological diseases, but as I said before, the thick of our work goes to ALS, that is lateral amyotrophic sclerosis. Before I give you some details on this disease, what is it that we're doing, I want you to understand what does it feel like for a person living with ALS to have this disease. So what you see here in the screen is a testimony by Sandy, an ALS patient, and she said, we need to work on the ALS clock. I lost the privilege of working on the human clock on January 6, 2018. My clock is a lot faster. That said, for us and Amylyx, we are all working on the ALS clock because we know how fast this disease is, how quickly the symptoms develop. That said, what is ALS? Well, unfortunately, it is a fatal disease characterized by a very quickly loss of function in the muscles. People will soon lose, or rather soon lose, the ability to talk, the ability to swallow, the ability to be independent. There are about 30,000 people in the European Union and the UK affected by this disease at any given moment. And from average 2 to 5 years, unfortunately, most of these people will pass away. And half of those will actually pass away within 2 years. So you see, it's a very bad disease to have, let's say. But again, there's something that can be done about it. And that is why in 2023, a stakeholder group of experts and people living with this disease and patient advocacies and so on, decided to come together and start the work of the European ALS Coalition, which Amylyx, among others, is very proudly a sponsor of. Now, thing is that because ALS, although it is classified as a rare disease, as a neurological rare disease, it is a very common one. In fact, it is classified as rare because, unfortunately, given the fast pace at which patients pass away, there's never really a very high amount of patients at the same time. But again, there is something that we can do about it, and this is why the coalition, and you see more details on the screen now, decided to draft a policy paper outlining a series of 10 policy recommendations that can be and should be implemented at the national level to improve the people of those living with this disease. The paper is accessible in the coalition's website, alscoalition.eu. It has, again, the 10 policy recommendations, as I said before, and these are structured, again, across 3 pillars, all tackling the needs of people living with ALS. And those pillars are, they require an optimized diagnosis because, as it is the case, as you mentioned before me, for other rare diseases, diagnosis takes far too long. And unfortunately, it comes late and not without a cost. Then the second pillar is ALS is a very complex disease that has a very quick progression, and therefore it requires matched care. And then lastly, ALS patients, and this applies to other neurological diseases, deserve a better prognosis than the one that they get at the moment. Taking forward the 10 recommendations of the EULS coalition, which again you can access on the paper, which is available on the website, an informal group of members of the European Parliament and national parliament came together and decided to work on this a bit further. That is why last September, and the European Brain Council was there as well, we hosted an event in the European Parliament here in Brussels with two MEPs taking the lead as co-hosts from different parties to present these recommendations to the wider audience and to get the talk started on how do we best implement this at the national level. This event also marked the opportunity to launch the group, of which I just mentioned the name. Members is an informal group of members of the European Parliament and National Parliament against ALS, and this group has been working ever since on this topic. Now, the work that the coalition is doing at the moment is they are organizing and executing a series of national roundtables across member states for the local upscale and implementation of these policy recommendations. Again, always in the benefit of people living with this disease, which are at the center of everything that the coalition does. A bit briefly to end here, I would like on behalf of the coalition, I would like to end with this call to action. You see two things that I think we all can do together. One is to prioritize neurodegenerative diseases on the EU health policy agenda of the upcoming European Commission and the European Parliament, and then also to enlarge the informal group of MEPs and MPs against ALS. At the moment, we have 6 MEP and 1 MP. We are, of course, in conversations to enlarge this group. Lastly, I will also say that we support the European Brain Council's call to have an intergroup on brain health and research in the upcoming European Parliament, because we consider this to be a very important advancement if we get there. Thank you very much for listening. I'll leave it here. So I understand there's no Q&A, but I'm available during the coffee break and lunch. So please don't hesitate. Thank you for EBC for the invitation and to all of you for listening.
You're launching those two ideas, and thanks for echoing our manifesto in that respect. I'm pretty certain that other organizations in the room will also have their contribution for the discussion. Thanks a lot to the two of you, and I'd like to invite for 10 minutes of questions that's possible so that we can resume for the next session. It's not working. No? My light is on, so I'm really sorry for that. Is it working any better? Ah, okay. So there seems to be an issue with the mic. Apologies for that. So 10-minute coffee break. Enjoy the networking, relax a bit, stretch your legs, and see you in the room at 10 to 12. Thank you. Please, as we are going to resume. And particularly as I was just told that our online colleagues or colleagues joining online were more diligent than what we are here in Brussels. And they are waiting for us to start again. And for that purpose, I'm really happy to hand over to our colleague and senior research project manager at TBC, Vinciane Quatbach, who has been working on the topic of rare diseases. And so, Vinciane, you're going to moderate the next panel. Over to you.
All right. Thank you, Fred. It's a pleasure to be here today. So this session, number 4, is about the clinical care pathways for rare diseases in Europe. We will have a panel discussion. And first, I would like to introduce Professor Paola Giunti. Paola is professor at the University College London and head of the Ataxia Center at the Department of Clinical and Movement Neurosciences at UCL. We have also online Dr. Anita MacDonald. Anita is consultant, dietitian in inherited metabolic disorders at the Birmingham Children's Hospital. And we have also with us today Giuseppe Turchetti, who is professor of management and economics at the Santa Lucia College in Pisa, Italy. So just a few words on the project. It's actually nice to share today also some of the journey and the results of the studies that we carried along those last years. The value of treatment on rare brain diseases. We have actually today already have highlighted a lot of major gaps along the care pathway. We talked about the care and treatment gaps like misdiagnosis, delayed diagnosis, lack of adherence for patients. We also talked about uncoordinated care, etc., etc. Today, the focus is on rare brain diseases, ataxia, dystonia as rare neurological disorders, and also phenylketonuria, who is actually a neurometabolic disease. We know, and the figures we're telling this morning, Magda said we have more than 6,000 rare diseases. 70% start in childhood, 75% have neurological origin. So we wanted to, with EBC, start a project on that. We had the collaboration of academic partners with us, UCL, of course, Cambridge University, and also the Pisa Santa Ana College. We also had the collaboration and the support of our members, among which the European Academy of Neurology and also the European EPNS Pediatric Neurology Society, among others. And so, yes, today we'll have the results shared, and I will give the floor to you, Paola, and also a few words on the methodology. We actually adopted the value healthcare-based approach. With that, we developed a tool which is actually called the clinical care pathway. This methodology was actually really useful because we looked at different perspectives, the management, the clinical also aspect, but also the patient perspective. Altogether, it makes it very useful. And so, yes, you have the floor, and I give you this.
Thank you. Thank you, Vinciane. And I really start with a very big thanks for EFNA and for the EBC. Indeed, if both of them together would not collaborate, I wouldn't be here. So everything started for me in 2016 when EFNA awarded me for the European Professional Healthcare Award. And at that night, I attracted the attention as well for Friedrich. And he invited me very kindly to present my patient-centered ataxia. There has been awarded an excellence for ataxia UK at the European Parliament, and then there was that occasion for the scheme of value of early treatment. We submitted soon then after the project on patient's pathway. So basically, what we wanted to do and what we wanted to see if patients who attended a specialist centers has the same journey of the one that did not. And we were then in collaboration with industries and Professor Steve Morris, a health economic, and as well Ataxia UK. And together we redacted a 64 questionnaires, 64 questions. So it was very comprehensive. And we launched this one first in the UK and then in Germany and in Italy to have a really nice landscape of, Europe. Brexit or not Brexit, rare diseases is basically global. So it's really, really important to highlight that we did it in 3 different countries. And the main focus was indeed a diagnosis. We have heard early on what is very important to have a diagnosis, a specific diagnosis, because I would like to highlight that not receiving a specific diagnosis is still a diagnosis. So we have in ataxias more than 100 different genetic disorders recognized so far. But for example, in my clinic, we have, for example, patients with specific genetic diseases, but 50% did not have it, but they still have a diagnosis of ataxia. And therefore, our as well main aim in the survey was the management. You know, very few people are talking about management, that it could be done in holistic approach, and it could be effective, as we can see here, because indeed when we looked at the satisfaction, indeed we had the positive feedback for the role of the SAC, the specialist ataxia centers, in understanding and management ataxia was clearly positive and statistically significant. And the same for the delivering of adapted care and personalized care. So for the network of referrals that are relevant for that particular patient. And what as well emerged that across the board, across the 3 countries, the barriers to access to specialist ataxia centers were very much the same. First of all, distances. And the traveling of patients, but also difficulties in make that referrals, to convince GPs to make that referrals to the specialist centers and others. And then for the health economic point of view, what was very comforting was that the resources were very similar. And so that's said that despite one can think that especially ataxia centers can be more expensive, that was on a whole and comprehensively not this the case. And I will stop here and I will leave. And then we will have Anita coming in.
Okay. Anita, over to you. We ask questions after your presentation.
Thank you very much indeed. And hello, everyone from Birmingham. I'm sorry I'm not with you in person, but I had a few technical problems with the flight yesterday. Today, I'm going to tell you about some casework we did on phenylketonuria. Phenylketonuria, or PKU as we call it for short, is a rare inherited metabolic condition. Without treatment, it will cause irreversible brain damage, but with treatment, it will still lead to a number of subtle neurological effects. In children, it can lead to deficits in cognitive functioning, behavior problems, attention problems, reduced school achievement. In adults, it can lead to deficits in executive function. The organizational skills may not be as good. They may have poor concentration. They often have mental health issues such as depression, anxiety, low mood. Socialization is a problem. They do live on the outskirts looking in at life, and often they have reduced work opportunities. And what we're actually finding is as patients are increasing in their time on treatment and getting older, we're seeing a number of comorbidities which are linked to the condition itself. Now, this is a condition that is identified by newborn screening. It's not quite global, but most European countries do implement newborn screening. The traditional treatment for this condition is diet therapy, but my goodness, it's a very restrictive diet therapy. It's restricted in protein. 80% of normal foods people with PKU can't eat. So no meat, no fish, no eggs, no cheese, no ordinary bread, no ordinary pasta, completely very difficult. And it's estimated about 80% of adults cannot keep to the dietary treatment that is prescribed for them. We have recent drug therapies introduced. We have a drug therapy introduced 15 years ago that's estimated that it will help 30% of the patients, called sapropterin. And more recently, we have another new pharmacological treatment introduced, an enzyme substitution therapy for adult treatment, for adults with PKU, but it's incredibly expensive. So treatment is lifelong. It requires a huge amount of self-motivation. We do have European treatment guidelines, and the purpose of the project that we did, we wanted to look at the treatment that was delivered in 3 treatment centres across Europe. 1 treatment centre was in Spain, 1 treatment centre in Dublin in Ireland, and 1 treatment centre was in the UK. 2 treatment centres looked at adult care, 1 treatment centre looked at the care that was delivered for adolescents. So the issues that we came up with, we found that we was all using quite different care pathways. This was in particular related to the transition of patients between paediatric and adult centres. We did find that the resources within these 3 centres, well-established centres, was quite different. And if we look at the staffing, this varied anything from 1 to 40 individuals with PKU to 1 in 120 individuals with PKU. The 3 centres had similar number of medical clinicians, but where we did differ is in allied health professionals like dietitians, with support workers and psychologists, was a very rare being indeed within our centres. Also, treatment access was very variable between the 3 centres. Although all 3 centres offered dietary treatment, one of the centres didn't reimburse for some of the special dietary products, which meant that the patients or the caregivers had to buy these. They were incredibly expensive, and this made the treatment less available. The 1 drug therapy, which would have helped 30% of the patients in our entire cohort, only 8% of the patients were accessing that particular treatment, and only 1 centre was able to access the very expensive treatment for adult patients, and in fact no patients was benefiting from this new treatment. So what we found was the new drug treatments was that our patients with PKU wasn't getting the benefit from this. Although we have the European guidelines giving the standards of care that we should follow and giving good guidelines on how we should monitor the patients, in fact, the 3 centres, we all did really quite badly. We weren't following the PKU guidelines to any great degree. And the way that we monitored paediatric patients, where we put more attention on the PKU and less on the other issues of care, was quite different to where they monitored the adult patients, who put more emphasis on comorbidities. We did look at the comorbidities that patients were developing, and our eldest treated patients had a mean age of something like 38 years, but we were finding that patients were having more comorbidities such as obesity, osteoporosis, and mental health issues. We looked at treatment costs, and the lowest treatment cost for our patients was actually in the staff resources. The next most expensive cost was in the dietary treatments, the specialist protein replacements and low protein specialist products. And the most expensive cost was the drugs that certainly some of the centres were simply struggling to afford. So what can we improve? It was very clear during the course of this work, we needed a lot more patient and public involvement, really giving us direction on how we should give the care and deliver the care for people with PKU. It was clear we need to work on our care pathways. They should be similar across Europe. People with PKU deserve to know how they should be treated for the condition. Because comorbidities are more prevalent with this condition, because the patients are maybe not doing as well as we thought, we need more patient registers to collect more information about the history of these patients. We need more equality of treatment. We need to be able to access the new treatments, so we need lower drug costs. And because maybe in the long run, we are not going to necessarily get more money for staff resources, we need to develop more smart working practices. We need to use the new technology that is available so that we can both monitor our patients better and we can follow up and educate our patients better. So that is all I want to say today, but thank you very much for this opportunity.
Thank you very much, Anita. It has been very insightful. Then maybe we can move to some questions, Paola. Thank you for your presentation. Just to say also, there are 2 articles actually that have been published in the Orphanet Journal of Rare Disease. One on the value of specialist centers and use of resource, and also the aspect of costs of those specialist centers in comparison with the standard of care and general hospitals. There is also another article specifically on the patient care pathway. Can you tell us more about the discrepancies? I mean, there are clinical guidelines. What came out from the research actually between those centers in the UK, in Germany, and in Italy?
Yeah, certainly there are these 2 articles that have been open access, so everyone can access it. It's in Orphanet Journal of Rare Diseases and has been published very recently in December. And so the first article is for the patient's pathway, and there seems to be a slight differences between those countries. And in the UK, it's submitted as I presented before. The satisfaction seems to be higher, slightly higher, but statistically significant compared to the others. And this is possible due, this is just an hypothesis of the fact that we have established these centers with the patients. So it's been always patient centers, and there is an ongoing survey. We have data for now 20 years since we established the centers, with the feedback constantly of the patients, so that we can shape the service exactly for the patient's needs. So, for example, we have changed changed the genetics, for example. There was a request of more genetic information, more research, and so forth. So this is an hypothesis. And for the economic point of view, there has been some differences, and we have seen that Germany is, especially ataxia in Germany, are more expensive. This is possibly due, again, I would like to highlight that this is where preliminary data, obviously this was the first ever survey that has been done with the patient survey, and try to identify patients' pathways. And it is possible something that is historically how the structure of the service is laid out, because we know that in the UK we have the NHS, and in Italy we have as well very similar. Has been actually the service has been laid out from the example of the NHS, whereas in Germany it was more insurance based, so slightly different. So that's could be account. Obviously, it would be very interesting, for example, to dig deeper in that and have a health economist, for example, from Germany and from Italy and the UK, and see exactly what is the differences and see what he come out, because that could be then a very important message for then changing as well, and make sure that in the differences it will be an equitable access for the patients without thinking at economic barriers.
Yeah, thank you, Paola. So the study really highlighted the value of those specialist centers. When we look at the aspect of the symptomatic management of the disease also, it's necessary to have coordinated care, but also multidisciplinary care pattern. It's really of high value. I mean, it's beneficial for the patient. You can look at actually from the response from the patient survey, but also from an economic perspective. Also, there are, as you say, differences between the countries, but all in all, it's beneficial to have multidisciplinary care pattern for the management of those diseases.
So patients really value the multidisciplinary input, and this is to, again, looking at differences in Germany, there's not multidisciplinary clinic, and whereas there are in Italy and in the UK, more in Italy than the UK. Obviously, this is some information that is taken from the patient, so we need to be very careful about drawing really a hard conclusion. And the samples as well, the largest was in the UK, nearly 200 people, whereas in Germany was much less compared as well to Italy. So saying that, indeed, this seems to be an approach that patients has really highly valued in the specialist setting and in the patients who were not in the specialist setting. So the patients who went in a multidisciplinary clinic that were not specialists were less, though, and compared to the patients who were in the specialist centers, but will have more access to multidisciplinary approaches.
Great. Also this morning, we talked about equitable access to treatments. What is the role of specialist center, and what will be their role in the future of newly emerging therapies?
Well, thank you for this, this question, because this is really, really topic. So, you know, we are very excited in the ataxia community because we have the very first ever drug that is the omaveloxolone, and there has been as well in which I personally have been very involved on the preclinical studies and the clinical studies. We have been a site of the omaveloxolone in Friedreich ataxia. So Friedreich ataxia is the most common type, a genetic type of ataxias, and I think that this will open up as well very important topic in how new emerging therapy are going to be then administered to the patients, and the role of the specialist centers as a connection among them, and because we need to have as well registry, and you know mainly the best centers are really the key to have this registry, and then to connect with many other neurologists, and keeping an eye on the effectiveness of this new emerging treatment.
Great. Thank you very much.
Thank you.
Anita, over to you. Some questions also after your presentation. Why was the monitoring approach so different between the three centers in Spain, in the UK, and also in Ireland? Because the teams were actually quite similar, but what was actually the difference in the management? You said that, one center was more focusing on children, the other was more focusing on adults, and also you highlighted the need to look at this transitioning aspect as
Yes.
crucial in the management of the disease.
Yeah, I mean, there was many deficits in the monitoring in particular. I think all of us was poor when it came to neurocognitive outcome and monitoring this. This is one of the recommendations within the European PKU guidelines, that we monitor the neurocognitive performance of patients every so often. Every one of us actually failed because we didn't have the psychologists in place to do this. It was interesting with the some of the problems with the monitoring was historical, and maybe a non-recognition of the problems that the patients were actually facing and developing. In the pediatric population, we put more emphasis on the PKU management in terms of the control of the condition, trying to maintain blood levels within target, was very, very focused on PKU, but unfortunately not focused on the global picture, the complete patient. We weren't necessarily looking at nutritional complications, nutritional deficiencies, even though this is a condition that requires a very abnormal diet. We wasn't collecting data in terms of comorbidities. We wasn't necessarily looking in depth at obesity, whereas the adult centres focused very much on looking at the comorbidities. They were looking for the problems of patients right from the word go, looking at cardiac function, renal function, but really not enough emphasis on PKU care and on the neurocognitive outcome. I think basically, if we had a mark out of 10, I think we all didn't really score more than 5 out of 10. And this was 3 good centres who are known for the PKU care, but every one of us could have done much better.
Yeah, that's great. And what about the guidelines? Those were released in 2017. As you say, there is a treatment for PKU, which is the phenylalanine-free diet. Now we have also the novel therapies. I mean, it's also something that the teams, and especially in the metabolic care units, they have had to adapt themselves into the management and the monitoring of PKU. What do you think?
Yeah, it's certainly the teams themselves have really developed over time. And one of the things I should mention that has happened, I say the resources to the clinics was very similar, but the size of the patient numbers were very variable. If I take, for example, the one centre in Britain, which was the paediatric centre, the PKU patients comprised of a population of 110 out of 1,700 patients. So the clinicians were dealing with many other rare conditions. They were seeing that PKU was sorted, and there was maybe less emphasis put in the PKU care than some of the other conditions which were more acute in their presentation. And so that the care in Britain was often more led by nurses, dietitians, and the clinicians would get involved more with the problems, although they do monitor them day to day in the clinic setting itself. In the adult centres, more of they had lower numbers of patients. So they had more time to spend on PKU care. There was more medical emphasis actually directed in the care, rather than necessarily allied health professionals being involved in the care. What will actually happen in the future, the adult centres are going to get bigger and bigger and bigger. They're going to get more of these other non-PKU rare conditions referred to them. And the worry is that the time and energy that will be spent in PKU care will get smaller and smaller, because the other conditions will take over, because it will see that this is a condition that is sorted, which it isn't, and they do develop a number of problems, and they do deserve very good care. So that is a little bit of a concern that we've got for the future. And we do want to be able to access the new treatments that are available, which do transform life. Being on a rigid diet therapy is incredibly difficult, incredibly socially isolating. It makes people feel different. If patients can go onto a drug therapy that will alleviate or reduce the need for the diet therapy, it will make their life much easier. But we need to be able to access those treatments.
Yeah, thank you very much. And actually also you highlighted the point of patient needs to, they need to know, they need to have also the knowledge about
Yes.
the therapies. And actually we'll move on to this new project that we have been able to launch in 2023. And it's about the case study of phenylketonuria. And we wanted to also see what actually are the needs in terms of information, education, and communication from a patient perspective, but also looking at digitalization, as it was also part of the conclusions and the evidence-based recommendations that we made as part of this project. Could you tell us more, Giuseppe, about this project?
Yes, thank you, Vincent. Good morning. First of all, thank you to EBC for inviting me, but also, and I would say most importantly, for having organized this beautiful day. Yes, as you were saying, I'm an economist. I'm expert in organization, and we strongly believe that organization matters in the management of disease, of any disease actually, but in particular in rare diseases because of their specificities and their complexities. So in the last years, actually, because it is important to highlight this, because the project you are mentioning is a development, an evolution of the previous one. We have developed together with the patients associations and the clinicians belonging to the VOT, participating in the VOT project, the patient's care pathway. You can see it in the upper right side of the slide. That highlights the different phases the patient goes through from the very beginning to the monitoring phase and long-lasting monitoring phase. So we drafted together this optimized patient care pathway for dystonia, ataxia, and PKU. This is the one for PKU. We adopted a methodology that is that we designed, that is called RAREN Path, that has been developed within a ERN program, in particular within a ERN Reconnect, that is one of the 24 ERNs. And we applied to these diseases. Then we thought about, and I skipped to the project, we thought about the experience that we had during COVID-19 and the role that digital tools played in the management of the relationship, first of all, the relationship between the centers and patients and their families. So the question was, what could we keep alive of that experience, and if and how digital tools could be included, adopted in some of the phases of the patient's care pathways. So this was the objective, the main objective of the study. So we tried to investigate the unmet needs in the use of digital tools in the patient's care pathways, listening both the voice of the patients, and I'm going to present the first results, but also of the healthcare professionals. And the collection of this data is ongoing in these days. So I will present only the patient's perspective today. So the question was, which kind of role do you think that digital tools could play in the patient's care pathway, and in which phases of the patient care pathway you think digital tools might play a more important role, might be more important to you? So this was the objective. So we asked to patients, trying to emphasize the different phases. So from the access, the diagnosis, the treatment, and the monitoring. In which of those phases digital tools might play a more important role. And in this respect, we try to, as Vincian was saying, to try to analyze which impact, in which dimensions digital tools could play in the different phases a more important role in information, in education, in communication, in favoring education, communication, information, and in particular in communication between the patient, family, and the healthcare professionals. So we co-design with patients associations a survey trying to understand these dimensions. It has been developed in English and then translated thanks to the contribution of patients associations in German and in Spanish, because this study has been managed, of course, with the coordination of EBC, with the collaboration of PKU Patients Association from Germany, Ireland, and Spain. So, and these are the main results from the patient's perspective. We got 75 surveys filled, and this is the distribution in the 3 countries. And these are some of the most important results. Information about PKU and communication about between patients and their families and the healthcare professionals have been rated as very or extremely important. So the role of digital tools in these dimensions have been rated very or extremely important, and basically almost by all of them, 94, 97%, and by 72% of the respondents, education on a digital platform about the management of PKU is considered very or extremely important. Then 75% of respondents believe that the use of digital tools, so email, mobile apps, WhatsApp messaging, virtual calls, for information sharing and communication between patients and parents and the healthcare professionals before the clinic visit can make the visit more effective. So here the answer focuses on one specific phase of the patient's care pathway. So before the visit by the center. 91% believe that the digital tools could be useful to understand the information provided on treatment and monitoring. So to have the possibility to rely on those digital tools, patients believe that the treatment and the monitoring phases could be more effective, could be easier. And the last result that I'm going to present is that 91% believe that digital tools for daily PKU management could be useful for understanding the information the patient receives from the metabolic team and for communication outside clinics. So it is a tool that, as it proved to be very effective during COVID-19 pandemic, still might represent a useful driver, a useful tool for keeping the day-by-day activity and the day-by-day communication interaction with the healthcare professionals more effective. These are the results, again, looking from the perspective of the patients and the families, because also family members answered to the survey. Stay tuned for the results coming from healthcare professionals, and at the end we will try to keep all these data together. Also benefiting from an ongoing study that patients associations are running that is very complementary with our study, and so the final results will be much richer than we expected at the very beginning of the study.
Thank you very much, Giuseppe. Let me just go back to the flowchart, which was actually the start of this new project. The flowchart is actually based on the rare ERN path methodology. As you say, it's coming from the ERN connect, but adapted specifically to this project, actually, it's really telling because you look at the different sequences, the different phase along the clinical care pathway. And this exercise actually was done in consultation with all the experts of the working group that was set up at the time. It's going to be published soon.
Yes, hopefully, yes.
We had already the article on the impact of COVID-19 on continuity of care.
Yes.
And also which actually highlighted the change in procedures, clinical procedures. Can you also tell us more on what actually is from the clinical perspective? And this is something we are on at the moment because we extended the survey. What is the add-on in terms of the relationship with the patient?
Yeah, as I said at the very beginning, we strongly believe that organization matters, and we have so many evidence on this respect. A better organization has a strong impact on health outcomes because the patient is really followed during the journey and the relationship with the healthcare professionals, with the patient. But it also improves the efficiency of the overall system. And so highlights the importance of a very strategic dimension in our nowadays healthcare system, that is the economic sustainability of the pathways. So an optimized pathway not only impacts on the health outcomes, and this is the first and most important objective, but also helps the system in being more sustainable also from an economic point of view. The third dimension that an optimized patient care pathway might deliver is the equity, to increase the equity of the treatment, because the pathway homogenizes the pathway, the clinical, the patient care pathway. So it reduces the differences that mean inequity in the pathway. So all the patients, no matter where they live, if there is a patient care pathway in place, will receive the same treatment, the same management of their disease along the patient care pathway. What is important, and this is really the root of Random Path and the adaptation that we did here in these diseases, is that it is co-design. It is not a top-down exercise. It's really a co-design between experts in the methodology, and this was basically our job. We did not draft the pathway. Clinicians, patients, their caregivers, their families really did the job. So we simply acted as facilitators, as methodologists in this exercise, but it was really co-designed by patients, families, and the clinicians. So we strongly believe in the importance of patient care pathway. The European Commission strongly believes in the utility, in the role that patient care pathway might play. For example, in translating the results of the ERNs within the single national healthcare systems. The European Commission clearly stated that please use patient care pathway to favor the translation of the results developed in the ERNs within the national healthcare systems. And there are projects going on and promoted by the European Commission in this respect. Thanks to ABC to having translated this methodology also to this kind of.
Thank you, Giuseppe. It's really about innovation and healthcare, and also for the benefit of the patients. I think we can move on to the next and last session, which is actually also on unmet needs, and we'll listen to the experts and their opinion. Thank you very much.
Thank you. Thank you very much, Vinciane, and thank you to all speakers and to Anita joining us online. can I invite Anna and Michelangelo to join me for this last session? So it's basically says open discussion on unmet needs. So it's going to be obviously very broad. You were warned to prepare your contributions, questions, and comments. Actually, I'd like to invite our colleagues online also to use the chat for any questions, because this is moderated by Christine in our team. So Christine, keep an eye on what's coming, and I'll give you the floor in a minute. But I'm here joined by Professor Anna Jensen, representing EPNS, the European Pediatric Neurology Society, as well as Professor Michelangelo Mancuso on behalf of the European Academy of Neurology. Obviously, you'll have the difficult challenge of helping me breaking the ice in this conversation. And I'd like to invite each of you maybe to come with a comment or maybe a reflection on the basis of what you heard so far, in order to get us and get the ball rolling in that last part of our session today. So Anna, maybe I'll say ladies first.
Shall I go
Michelangelo,
first?
if you don't mind. Yes, okay.
Yes, so I'm here on behalf of the European Pediatric Neurology Society, and I think when you heard that 70% of rare disorders start in childhood, and at 75% of neurological etiology, then we're important allies in the rare community, rare disease community. I maybe want to share two highlights that I really took with me this morning, and I think the first one is not taking away any of the focus on research and innovation, on awareness, diagnostic capacity. I think my important spotlight, or I would like to put my spotlight on the need for integrated care and the organization of care, what we also just finished with. And that also came across at a BID in 2023, is the need to really integrate rare disease care into our existing health systems. And I think it's a challenge that we are still struggling with a lot at many different levels. And that resonates a lot also with many of the other comments that came earlier today, is the need for a holistic, comprehensive care. Rare disorders are very often multi-system disorders and chronic disorders. So the challenges to organize care are often very high because we need to collaborate with many different stakeholders. But if we really want to do something at a not just on the medical level, but also on the bio or the psychosocial level, as Matt also highlighted, tackling the isolation, the financial burden, the emotional burden, then I think this is something that we really strongly need. And maybe if I can, a second spotlight would really be to advocate for, and it's also something that came across in the last presentation, is to advocate for multi-stakeholder participatory research in the field of rare diseases. It brings a lot of stakeholders together. There are a lot of different needs, but I think we need to make sure that the priorities that are set in research are really strongly aligned with the priorities of the community, and that we make sure that we don't have any mismatch there. And so I think one of the methods is to make sure that we speak to each other, that we speak the same language, that we involve all stakeholders. And I think the rare disease community is already doing a very good job, and also EBC, by facilitating all stakeholders coming together, industry, physicians, patient advocates, clinic. So I think that's important. We need to foster that very strongly.
And just two quick comments before giving the floor to Michelangelo. First, thanks for, wearing the colors of rare diseases today. Well done.
In solidarity.
And showing diversity there. Just a quick question on multi-stakeholder participatory research. How do you experience that in pediatric discipline, and what would be the challenges in your view in child neurology in particular?
I think it's really, for me personally, it has been a game changer in my personal career. The first time that I engaged in a multidisciplinary participatory research trajectory, it just made such a difference. It's easy to keep your energy because you know that what you're working on is relevant for, it tackles an unmet need directly. So it just helps you to keep going.
to bring energy. And I think it is in the pediatric neurology community, it's very strongly needed. We need to, the things are, we still need to learn so much. Also natural history, many of these diseases are chronic. Very often we don't have a clue, how do individuals with a rare disease that starts in childhood, how do they age? What happens when they become adults or grow old? Are there things that we should look after? Can we prevent things? There's still so much that we need to find out, and it's only by really collaborating adult neurologists and pediatric neurologists as well, and mental health specialists to make sure that we tackle all these different aspects. So it's an opportunity, I think. It's a challenge, but I would see it as an opportunity.
Okay. Thank you. So perfect transition to bring our expert in adult neurology on board. So Michelangelo, over to you.
Yeah, I absolutely agree. Transition is one of the goals we have to achieve in the next 5 years, I guess, because there is still a lot of work to do. It's not always easy, unfortunately, at the local level to deal between adult neurologists, neuropediatricians. They can be located in different hospitals, different cities, different regions, right? So transition is absolutely one of the goals of the next future. We should try to work more on transition. From my point of view, I'm representing the European Academy of Neurologists, which represent more than 45,000 neurologists coming from 47 countries. And within the European Academy, we strongly believe that it's very important to work on rare neurological diseases. In fact, we do have a coordinating panel on rare neurological disease, which is very, very active, I think. And then one of the message we as a European Academy, as coordinating panel, we are trying to maintain alive. Actually, we published last year for the 2023 Rare Disease Day, we published an editorial on the European Journal of Neurology with the key priorities to be achieved in the next few years. I don't have time to go through all the key priorities now, but one of the absolutely still huge issue we face in Europe is the inequity, not only at national level, but also at the European level. We published 1 year ago, I think, the European survey on the neurogenetic screening, the newborn screening across Europe. And you cannot believe how different is the situation from country to country, even if you think about the most evolved countries like Italy, Germany, France, UK. There are still regions within each single country where they do not perform newborn screening with the new disease where we have a treatment. There are entire countries in Europe where they do not do at all newborn screening for SMA, for instance, right? Just to give you an example. So there is a huge need to work starting from the newborn screening, also the prenatal screening, which is still very, very behind. We have this new treatment coming, the Friedreich treatment, but let's focus on what's going on with ALS now, with the gene therapy on ALS and many other disorders. So this is, I think, one of the most important points where all the stakeholders must collaborate. And the last message I want to deliver to the room is the importance we're doing today to put all the stakeholders in one room, because sometimes, clinicians are dreamers and they live, the scientists, they live in their little lab exploring whole genome sequencing, discovering new little genes that may modulate the phenotype of another disease, but this lab is alone if it doesn't talk to pharma that can develop the drug for this modifier gene, if this little lab doesn't talk to the politician who have to start thinking about the newborn screening for this new disease and so on and so on. So we need to work together, and EBC is doing a great job, I think. So,
Thank you, Michelangelo. I think a lot of what you're saying resonates very strongly, bringing stakeholders together, obviously, and engaging in those discussions. But as we were saying about like creating a wish list, making the dreams of clinicians and scientists come true. If we can dream big, could be another one. Just to come back on the publication you made and the point on inequities, would there be other areas than screening? And I would probably extend to detection, that where you identified inequities, or would that relate also to access to care? For instance, would you have like concrete examples of that in the work that you've been publishing last year?
For instance, we were exploring the access to the gene technologies country by country, moving from single gene search to whole exome or all exome genome sequencing, or available NGS panels for cerebellar ataxia, for instance, as was one of the questions. And yeah, there is a huge discrepancy also in terms of genetic testing available, reimbursability, and the time need to have the answer. For instance, in the eastern part, I don't remember now the numbers, but the more east you go, the less exome and genome sequencing you have available, reimbursed by the health system, and the longer it takes to have the answer, for instance.
Okay, thank you. And I suggest that maybe the publication can be made available to all participants, and we can create resources on our website as an outcome for this meeting. And a quick reaction, and then we throw the ball to the audience.
Just listening to you, I was also thinking that there is a discrepancy at the level of education and training. And I think therefore it's also important for our societies to try and make sure that we train and educate in the field of rare neurological disorders across the lifespan as good as possible. And I think it's one of the things that we can try and tackle together. Yeah.
And we were touching also this aspect in the European survey, and more than 95% of responders think that we need to do more, starting from the medical school, going to the residency program, and so on. And this is from Italy to Germany to Bulgaria, everywhere. So it's a clear unmet need for doctors.
But that's also a great example of one need that we identify collectively, but where we see that your respective societies are the best place to actually act upon. So, and it's great that actually this is identified, being targeted, and let's say put in place or pushed forward. Now I'd like to invite audience or attendees to take the floor to provide comments. Otherwise, maybe Christine, I'll call on you. But Matt, you have a question or comment?
I've got two.
And Godfrey, if the other mic can go to Christine, because I'll give her the floor next. Thank you.
I've got two. One to the European Brain Council. The ecosystem which we're trying to create around rare brain disorders or diseases requires partnership, strategic partnership, multi-stakeholder partnership. What are the strategic goals which you are putting in place which enable or mandate the multi-stakeholder community to partnership? Because I think we need that to take forward this further. So that's one question. And Anna, you mentioned about coordination of care, because these are very multi-system conditions. It's very difficult for clinicians. We know that from the patient community, because the lack of coordinating care which we see in healthcare systems falls to then families and parents to do that coordination function, which leads to poorer mental well-being, etc., etc. So how can we empower patient groups and individual families with these European guidelines to know this is the care which I expect to have, and they're the ones, the catalysts in the system, saying, well, actually, I go to the centre in the UK or in Italy, and this is what I need for AKU or PKU, sorry. So how do we empower the community to be the drivers to advocate for the care they need, rather than expect the clinical services to do it because of the variation?
Thanks, Matt. Anna, would you like to respond first?
I'm not sure that I have the perfect answer. I think it is a challenge, but I do think that families and patients advocacy groups are a huge driver of change in this space. And yeah, just being aware of care pathways, of models that exist that already have been implemented and are successful. I think that's one of the advantages in the rare disease community, that some of the models that might work and have been studied and implemented for one disorder could, with slight adaptation, for example, be transferred in another space. And I think it's just very important. And I think many of the associations like Eurordis, for example, what they can do is be aware of what works in one rare disorder and then empower another rare disease community or in that area to try and advocate for something similar. So we don't have to reinvent the wheel all the time. We can really learn a lot from each other, from what has already been done, what is available. It's also making sure that we share knowledge and make sure, yeah, just also listening and sitting here this morning, I have discovered a lot of new things that I thought like, I didn't know that this existed. This person has done that. That might be useful. So I think it's also on days like this that we share our knowledge and that we know who is working on what and who could help us move forward together. Yeah, so it's maybe not very specific, but that's what I would reply.
Michelangelo, you have elements of response to?
Yeah, and if I can add a comment, I think another good place where to start growing and then transferring at the local level is the year ends. Because as you're aware, I'm sure, within the year ends, we develop patient journey, clinical pathways, clinical decision supporting tools. And in all these tables, there is always a patient representative. And we do this for each single disease covered by each single year end. So if the delegates from, let's say, mitochondrial working group, where I'm more involved, we develop clinical care pathway, patient journey. The patient representative will have to spread the voice to the members of the different state members. And so within Italy, Germany, UK, Bulgaria will know that there is a clinical care pathway on mitochondrial disease. And with this clinical care pathway, you have to go to your ministry, you have to go to your clinician, say, look, there is a clinical care pathway now, you have to follow this.
Thank you. Okay, quickly.
It also requires policy just to make sure that we can implement it. I mean, we can have a huge drive to make change, but it needs to, you need a soil to seed it in and then it can grow. So we also need a policy for that, I think.
Well, what's great is that, again, you provide the right transition, because I still need to respond to Matt. No, but on the policy side, and I think it resonates also for the strategic objectives, I'll make what could be a long reply extremely short. As I was saying, our vision was to say the ecosystem can be an enabling framework, bringing all stakeholders together, as it was already repeated a couple of times. But I think that the strategic orientation and objectives are in the making. It's exactly what we have been doing since this morning. And we are extremely grateful for your collective contribution, but also very eager to see this developing. I think we touched upon quite a few of those, and we'll come to that in the kind of summary report of this meeting today. But the idea being really to build on the need identification that we have been working on since this morning. Yeah. Christine, I'm really curious to hear what's cooking online in the chat. I see numbers growing up on the contributions from a colleague having joined us online. So can you give us a flavor and a bit of a summary of what is being said?
No, of course. So there have been some comments and there have been some questions, especially towards the end. So I've tried to capture all of them, but I think we can really see like two main themes. Like one is the relationship between the patient and the healthcare provider. And then one is also what industry can do. So basically, to start with the first one, the result is still a lot of misdiagnosis and confusion. And the patients, yeah, they have the feeling that healthcare professionals, they're not able to give information because basically there is no evidence. And if evidence is existing, it's very often also not representative. So very often it's genetic information is only about, you know, Europeans or like very typical, but not really representing the current society. So that's one point. A solution that has been given was to train medical students and healthcare professional to recognize red flags. Then, okay, my question would be like, what are these red flags? So that's tricky, but, and then there is also, if information is existing, actually there is a lack of access, like where to find this information. So there is a lot of information, but even though it is existing, patients do not know where it is. So that's another point. Also about the GPs, they are very often not having any information. You know, they have a very general overview. So even for a GP to recognize red flags or to say like, look, in your family, there is a genetic disease or a rare disease, you know, like going around. So that's another point. And then also actually something that GPs and healthcare professionals, they could already do is to really emphasize the importance of looking for care and looking for treatment. To not just say like, look, we don't know and that's it, even though there is nothing. You know, it's, I think, what we spoke about the psychological support, to do something. It's better than nothing. And then also, of course, patient organizations, they need funding to improve the information, but also to really work on this improvement of linking the, of providing the information to the patients. Because without funding, they cannot do anything. And very often they only work with volunteers. And this brings us a little bit to the next point. It's how can industry help patient organizations to improve care? So that's one point. Another one is what is preventing pharma to invest and innovate in the rare brain disease space? And also what can be done to really improve or to promote R&D in this area? So this is in a nutshell what was going on online.
Great,
And,
thanks. Thanks for that summary. I guess that red flags, white spots this morning. So we are in the color code of your nail polish, Anna. On the point on industry, we've got Matthias, Juan, Sofia. I certainly don't want to put you on the spot, but I'd like to really emphasize how open the floor is if you'd like to react to this, particularly in the space of R&D or support to patient organizations. I don't know if you would like to comment on this. Not necessarily. Yes, Matthias? Yeah. Yeah. Can you give the mic to Matthias?
Thanks.
Please.
There's certainly no one answer. I think it's a combination of factors. Things like this, where there is a community, obviously helps, right? When there is knowledge, when there are experts, when there is a community, where there is a voice from the patient side, where there is some understanding of a disease versus no disease, right? Coming back to the question of, you know, what is a precondition to take up and do some research. So it's a variety of factors, and then of course it's the expertise, it's the centers, but of course it is also kind of the framework conditions, like we are seeing with an orphan drug legislation. Is there a recognition that some of those, you know, developments might face different challenges compared to more prevalent disease areas when it comes then to the questions of bringing that treatment also onto the market and as such to the patients. So it's a multitude of factors, but right now, certainly, as we sit in Brussels, there's a great opportunity to, you know, put the right guardrails in place for the next 15 to 20 years, I'd say, in that space. Thanks.
Thank you, Matthias. Sophia first,
I was
and
given the
then
mic, but you know, to
yeah,
reiterate
no,
what
but look,
Matthias, no, but
serendipity.
Happy to reiterate what Matthias said, and we heard it from Magnus this morning as well. You know, I think there's a whole range of challenges that, you know, I think we can identify in the different steps or different phases of, you know, tackling rare diseases, you know, starting with the no knowledge on some of the diseases, right? And from that, you know, to the access point, certainly, you know, even when we do have the therapies and innovation, it's not always, you know, simple therapies and simple innovations. They are to be administered. You know, we need the awareness and the knowledge of healthcare professionals, and there's a multitude of challenges which definitely Natalie Moll often says, if we solve the rare disease conundrum, we basically solve a lot of things in life, and I think that's certainly true to respond to the question. So I mean, without an answer, but to say complex, but I think we're in the right path. At least we're pinning the challenges and hopefully making progress on some of them step by step. Yeah.
Thanks a lot, Sophia. And Tim?
Yeah, so I want to speak about, again, from the family perspective, and speak about the, I think, incredible potential of patient organizations for rare diseases. What I've experienced is first going through the phase of the more general epilepsy patient organization, but in the end, you have the feeling they really don't understand me really well. And then we encountered the Ring 20 organization. We don't need to explain anything to each other. We understand each other. We understand the sometimes awkward elements. And with that organization as an example, so there are 200 people with that condition published. We are an organization of 120 families worldwide. We have now set up a new scientific advisory board with 12 top neurologists, children's neurologists, and researchers. We are pushing now, I think it's 3 research projects on the genomics, on natural history study, etc. We are sharing from, we did patient and family interviews, talking about the natural history, but also talking about medication, what worked, what absolutely didn't work. That is feeding into the scientific advisory board to put down, I don't know the term, but the typical pathway of drugs for a patient like that. And then with that scientific advisory board, that's your dissemination then about the core elements of that rare condition that can go to the neurologist organizations, to the neurologist on the floor. And that can even inform your GP. Because for us, our GP is the person who keeps an eye on the comorbidities between different elements, the causes of the drugs, etc. And I think the patients, the very specific patient organizations, there's so much we can leverage from there.
Excellent, team. Juan, please.
Is it on? Can you hear me? Well, thanks very much. I just wanted to make one last comment on the challenges and the difficulties for developing medicines in the rare neurodegenerative disease space. So as we know, there is, we like heterogeneity in presentations, and there's also the impact on the whole body, which makes it difficult to measure outcomes. And then the need to cross the blood-brain barrier, along with all other challenges that are linked to rare diseases or to small diseases, such as, for example, the long diagnosis, the difficulties in coming up with the diagnosis, the need for mature care, the need for a better prognosis, and so on and so forth. So I also wanted to mention that, as I said before, the policy recommendations that the ULS Coalition has put forward may look tailored to ALS. Well, in fact, they are, but with some work, they can also apply to other neurodegenerative diseases, because I think that at the end of the day, all patients or all people living with a rare disease, they want the same, right? Which is faster and better diagnosis, better care for the disease they have, and in the case of fatal diseases, a better prognosis as well. Thank you very much.
Thanks a lot, Juan. And I think to your point, if anything in what we do can help make the recommendations of the ALS condition resonate or have, let's say, tangible anchor with a work more generally at the level of rare brain disorders. I mean, of course, same with what Orla was presenting with the charter. Obviously, we're there to try and create a kind of more larger framework, but also to then connect with more specific initiatives in the same vein as what we heard earlier about dystonia, PKU, ALS, as more concrete examples. So maybe Anna, Michelangelo, I'd like to invite you for maybe a last word, as I realize we've been beyond the time that was allocated to us, and I'm pretty certain that the stomachs of all of us are just like crying. As our president working in nutrition would say, that's now the center of everyone's attention, and nothing of what can say, you know, would be of interest. No, but more seriously, I'd like to invite you for maybe a final word, and also maybe with a view as to how the conversation we just had this morning can be continued, and what are the axes. I think we touched upon a few elements, but if there would be like one or two very concrete priorities that you would see would deserve attention in what was said this morning. So, Anna, you feel like starting?
Yeah, no,
Or
okay,
you can take the time Michelangelo speaks to think. So you know it's okay, Michelangelo.
Well, if I have to mention two major take-home messages, I think the first one is to overcome the barriers, inequities within countries, even before thinking about at the national level, because at least at national level, we have the networks, you know, it's quite easier, but we have such big barriers through Europe. And so we need to overcome these barriers. And the second big message is education and awareness. Education for the young doctors, the young physicians who are still in training, who are still in the first year of the medical school, and this has to continue during the residency program, and you know, maintain high level of education on rare disease also after the residency program. These for me are the most important points in the very next future.
Thank you, Anna.
I think, yeah, I want to once again more highlight the multi-stakeholder collaboration, and maybe briefly linking back to what Tim highlighted from the Ring 20 community and the industry aspect. I think also one of the opportunities would really be to develop or use digital technologies to bring specific knowledge on a rare disorder and these stakeholders together to empower families to drive progress. I think digital technology can leverage, can bring down some of the barriers that some of us are, or that's people are focusing in different areas in Europe, because it is accessible to everyone who has a smartphone. So if you have technology that brings specific information around a rare disease together in line with what the community really needs and can feed in what is going on and where the field is going to, I think that might also be a tool that could be very powerful, bringing, coming from industry and joining forces with the patient community and the physicians and the researchers. So I think that's my final thought that crossed my mind.
No, super. And actually, but just as a way of conclusion, as time has now elapsed, I simply first would like to thank everyone for your contribution, to our panelists, all the speakers, and to all of you for contributing your ideas. As I was saying a few minutes ago, these are really important contributions in us shaping what are going to be the next steps in our journey. But what I would retain is really to try and close with our first speakers, is really to try and defragment the great science we've got in Europe, how we can make sure that this is getting translated, how we can make sure that it is improving outcomes for people living with rare conditions, but also that in view of the political momentum that we are going through and the next phases, and particularly the next framework program for research, all the big initiatives being launched, the Rare Disease Partnership, the Brain Health Partnership, we really try and find as many synergies as possible, really to try and avoid duplication of effort. This is definitely something that at EBC we are working very strongly upon. And obviously there are very critical challenges that I will certainly not repeat, but were eloquently mentioned and singled out. I'm thinking that in some conditions, as I was telling in my reply to Juan, we can certainly try and propose quite a few things. Let it be ALS, let it be GMG, let it be work being continued on PKU, as we are now expecting the outcome of our value education piece of work. So there is definitely more to come and a lot in the making. You can really count on EBC as really providing those resources to try and meet these expectations, or to try and continue generate those ideas and pick it up and transform them into very concrete outcomes. Our next milestone in our journey is actually next week with the Brain Awareness Week. So you're all invited to join our event in the European Parliament, even though I'll be blamed by colleagues because I believe we are at full capacity already in the room. But if you manage to squeeze your way in into the European Parliament and join us, you're more than welcome, of course. And as it relates to this event, the report and recording will be made available to you. With the agreement and permission of the speakers, the slides will be made available to you as well. Additional resources as the one proposed by Michelangelo, but I would say proposed by any of you that you think would be worthy of being shared to our group. Please feel free to contribute those. And my last word will be a big thank you for all of you for joining today. A big thank you for all the speakers and the team having supported this event. Christine, Vinciane, and colleagues at the back who have worked on putting all of this together. And the last word of thanks to our sponsors of the day and supporters, Amilix and Alexion. And obviously, as we go, we would like also to invite anyone who would like to contribute and propose ideas to carry on and move that dialogue forward. So happy Rare Disease Awareness Day, and take care of yourself, and looking forward to working together. Thank you.